Hump Day.
Joining us now, Dr. Jennifer Bryan, the Board of Trustees Chair of the Mississippi State Medical Association. Dr. Bryan, always good to see you.
Good to see you, too, and I appreciate that. I'm past board chair, but thank you for that.
Board chair. That's right.
It.
Yeah, that's right. That's right. You told me that last time.
The AMA delegation. Yeah, thanks.
That's right. Yeah, we got it. But so healthcare, front and center, continues to be a big issue in this country, nationwide, and I guess, at least as far as the president's concerned, the pandemic is behind us from an emergency perspective, right?
Right.
But we still have cases on a daily basis. However, it doesn't seem that we're seeing as many that are requiring hospitalization,
Thankfully.
Intensive care.
Right.
That maybe the disease isn't quite as serious and threatening, COVID, as it once was. Maybe that's a combination of vaccination and natural immunity, and maybe the virus itself just isn't as powerful. Maybe all the above,
all
right?
of the above, and you were spot on. That's right. I mean, all of those things.
So that's good.
It is. We've got some good news, right?
But we had, her name escapes me, pediatrician on a few weeks ago talking about RSV. Mm-hmm. And how that has absolutely just ravaged the children's population in the state and nationwide. And in fact, I seem to recall that she told me that the very day before, at 5:30, there was a line of people outside the clinic, I think in Hattiesburg, if I'm not mistaken. Mm-hmm. And of course, this was children. I mean, it's a children's clinic, and across the board, it's RSV.
Yeah, well, first, let me just thank you for the attention that you personally have put on healthcare in our state, because it continues. You're right. So COVID's better, and we appreciate that. It's still a thing. But in the wake of COVID, we continue to deal with increasing respiratory diseases. You and I were talking just a minute ago about, the precautions that we took, that we needed to take for how bad COVID was in 2020 when it was at its worst and we had no tools and so on. We protected ourselves from other things, and the immunity there, while we have some partial immunity, it's not long lasting, and so it's catching up with us that we're catching all of these things early, and the hospitals are beginning to feel the strain. Doctors are. My clinic is full of everything from mono to strep to flu to RSV, COVID. Everything is it's seemingly back with a vengeance at once.
Well, it's certainly also being exacerbated by the challenge of just having enough people. I mean, businesses across the country, across all industries and trades, are struggling with just getting enough people to do the work. But this has been going on in healthcare. It was a problem before the pandemic.
Yes.
It ratcheted up, it amped up significantly as a result of the pandemic. We just have more sick people.
You're so right. So more sick people, less healthcare workers, although technology is catching up and healthcare is learning to work smarter, not harder. Those things take time to evolve, but I am seeing that we are adjusting and learning. And so there's a lot to catch up on, a lot of missed things over the past few years. There's so much at the same time. And then the public, the unrest that's out there, we see that when you look at other headlines that are out there, the people in general are frustrated. Yeah. And that spills over into an access to care issue with frustration and long waits, as you mentioned. And so, we continue to ask for patience and are appreciative of the public as they work with us, because times are still trying. They are some better in some ways. And as we enter the winter, it's going to get worse from here for a little bit. Hopefully nothing like some of the nightmares we have experienced, but it's still going to be tough times.
Yeah, and I was sharing with you before we came on the air that I caught a report yesterday on the Business Channel that was from and I don't remember the exact formal name of the organization, but emergency care physicians.
Gosh, yeah.
That are sounding the alarm that it's crisis situation. Mm-hmm. ERs are filled. And then the problem is we don't have enough nurses in the staff beds to move them out of the ER, patients out of the ER, into beds when they no longer need emergent type care and treatment, right? Right? And then that clogs up the system as far as taking on new patients that need emergency care.
It's so American, I guess, if we think 2019 and before, that we kind of want what we want right now, and that includes health care. And sure. I wish it was 2019, but it's not. And so we continue to experience long ER waiting room waits even when we're not surging. So December and January, look for longer waits, and particularly we're eyeing the hospital situation and the emergency access across the state, because when one closes, there is no magical place for anybody to go, and so it just compounds. So it's all of the things you mentioned at the beginning of the show stacking up. I had a family member last year, and we were visibly the sixth one in the waiting room, but there was no bed, and we just sat. It's sad. It's unfortunate, but it is our reality.
Well, if you talk to anybody that has unfortunately had to go to the ER because they had some emergency situation that warranted it, it's difficult, and the staff there are doing their best to triage the patients, but they got limited resources relative to the demand from the patients that are coming in. And
they were already burned out.
Yeah, that's right. Exactly. I had to take my wife like 3 or 4 years ago, had a kidney stone issue in the middle of the night, and went to a local ER, and it was backed up even then in the middle of the week. And that was pre-COVID. And while she was in pain, you had other patients coming in that were experiencing chest pains. My understanding is they go to the top of the list when they come in, right?
Right.
Because that's life or death situation often. And there was also a patient I remember in there that was suffering sickle cell anemia type attack reaction.
Painful.
Very painful. And honestly, I felt so bad about that. I went to the triage nurse and said, is there anything you can do? I mean, it was bothering me watching the patient there in the ER suffer like that.
What's interesting, too, in the clinic side, it's day after day of a patient will come in and say, I just need to let you know that I had trouble getting a call across, or I didn't get a medication or a referral. And we have gotten used to saying, yeah, we know. I'm so sorry. And so we continue to evolve, and I think that's way better than it was even 6 months ago. But it is a learning process for all of us to adjust to less people and also less resources. We continue with supply chain issues and medicines and so on. So it continues to snowball, and the public can continue to help support.
Yeah. And then we have the business aspect of this, the economic aspect. And that's broken, clearly, and there are warnings coming from, especially from the community hospital, the rural hospital community. I had the Mayor of Greenwood on a couple of weeks ago, and you got the Greenwood-LaFleur hospital situation that, honestly, I don't see how they're making it day to day.
I don't know what their path is out of this, and it is heartbreaking because my family's from up there. I mean, to see what is happening there is a tragedy. But then 54% of our hospitals across the state are at risk, and while I have typically advocated for physicians and physician practices and patients, this all affects all of us.
Yeah.
If a hospital shuts down, then the physicians are affected. They leave the community. The patients lose access. It's all connected, and the jobs that are associated with it. The economic impact is profound, but the access to care, which is already so difficult in these trying medical times, it just is really alarming. But we were talking. There are people looking at ways to pull us out of this, and I'm confident that we're going to move forward. We're going to look at it thoughtfully, and our leaders are looking at it and having hearings. The
state Senate, in fact, did conduct a hearing on Tuesday, and they came out with some recommendations. Some of which I'm not quite sure of all the details associated with them, but one was to reduce or eliminate the hospital provider tax, and I think there is a tax on per bed, if I'm not mistaken, is the way it's levied. Increase supplemental payments to reflect average rates, not a percentage of Medicare. And I think what that's saying there, Dr. Bryan, is we've explained that before. You got different reimbursement rates depending on who the payer is. So there's got private insurance, Medicare, Medicaid, and maybe some combination and all things in between. It's so dang complicated, nobody can tell you what it's going to cost before something, and then after it, you're still confused, honestly, after you get it. But so they're trying to figure out a way to make the supplemental payments that comes from government to be more indexed, is the way I interpret this, to average rates across that spectrum as opposed to just Medicare, which is actually in the middle. And then create low-income payment pools. That kind of sounds like, to me, something in lieu of Medicaid expansion, maybe?
Yeah, I think so. And I'm glad you brought that up because, it's the hot-button topic. And And there's some interesting things that I've learned. You know, when I was chairman of the board, I've created the task force that looked at a lot of this. That actually, before he was state health officer, Dr. Edney chaired. And we really looked into this and talked to the economic leaders, the other states, and different things. And so what is being looked at are other ways, right? Instead of just, like, let's expand this across the board, traditional Medicaid, that's not really what people are talking about. There are some models when you're talking about 200,000 folks that are working poor that have jobs but no access to that insurance, right?
Right.
How do we help those people?
Let's talk about that after the break. You can hang around?
Absolutely,
We got Dr.
thanks.
Jennifer Bryan in the studio. Stay with us. We're talking. Welcome back, everyone. Midday, Super Talk Mississippi. We've got Dr. Jennifer Bryan from the Mississippi State Medical Association, former Board of Trustees chair. So you were just talking off the air about how to address this situation with the uninsured population in Mississippi and really across the country. But when I interviewed Mayor McAdams of Greenwood, she informed, as I recall, that 80%, I was shocked, of care provided by that hospital is absorbed by is done for free without reimbursement, no payment for those services. I don't see how that works. You got no revenue stream. 80% of what you're providing is not being paid for. I mean, that economics won't work.
They don't work.
They don't. So I just happened to mention that with the passage of the Inflation Reduction Act, there's a provision in there that fairly dramatically expands the premium and the subsidy structure in the ACA exchanges. And what it does is it reduces the amount that a subscriber has to pay as a percentage of their income by increasing the income thresholds in the graduated scale. So for an able-bodied adult, which is not qualified for base Medicaid, that's what Medicaid expansion does, is it extends Medicaid coverage to able-bodied adults. Currently, in base Medicaid, able-bodied adults are not a qualified coverage group is what they call it. But anyhow, they could go to the exchange and get coverage if their income is less than 150% of the federal poverty level for zero cost premium, and then get subsidies to help with their part of the cost of health care in the form of copays and deductibles and so forth. It seems to me like we ought to really be all over this.
So two things. One, certainly I think that people who do qualify for that should be looking into it and checking into it and making sure, hey, is this an option for my family? But the other issue too is, the words Medicaid expansion, they've just become so difficult. But it's the situation. There are ways to expand access to coverage that are not expanding traditional Medicaid, such as, if we were to look at some of the federal dollars that have been available. We're now one of 11 states who have not accepted those federal dollars. There's access to private insurance plans like Arkansas has done. It provides competition in the insurance market. Monopoly effects seem to go away. Hospitals stay open. However, how you look at it, right? These are able-bodied families, as you said, that can work. And maybe the premiums many times are too expensive on the paying for the private policy. I've looked at those for a family member. They're very expensive. So these things are working, but it's how we look at them and how we do them. And I wanted to say something about sequestration. So when the Affordable Care Act happened, a big portion of that was paid for on the backs of doctors and hospitals and other providers. We had $4 billion in cuts over the past decade in payments, while we passed on the $10 billion, in the expansion dollars. So understand when we're looking at this that there are federal dollars that we took in cuts in providing care through a global pandemic. And I'm not sure people are aware of that. And so as that is decreasing, there are federal dollars there that basically doctors and hospitals and others paid to expand this, and
in the form of Medicare reimbursement cuts.
And our taxes and so on, all of our taxes we are paying to expand in the other states. So when you look at Louisiana, their hospitals are not closing. Arkansas. So it's very complex. There is somewhere in the middle a workable solution, I am sure, if we look at this.
Well, I was reading yesterday the number of those enrolling in the ACA exchanges, so-called Obamacare, is biggest ever. I mean, it's off the charts. I was shocked at just how much that increase is. I'm looking for the exact figure, but it's substantial increase over prior years. I think that's because the subsidies are so much more generous, and somebody's figuring it out. But in lieu of expanding Medicaid, we could do this. It's paid for. It costs the state nothing. And so those that would otherwise be qualified to sign up for Medicaid in an expansion environment could go to the exchanges and get private coverage.
And I think that you are right in the families that, you know, within that percentage poverty level we were talking about that can afford it. Of course, they do have the copays and deductibles, and when you add all that up, I hear you. And if they qualify, let's do it. But there are able-bodied folks working full-time jobs that cannot afford that too. And so it's looking at the whole picture. We can't fix everything for everybody, but we got to start somewhere when we're on the bottom by a mile, as we've talked about. So there are ways to be fiscally responsible and also economically boom. I mean, when we look at this, the money into the community would be immediate. And we invest in so many things around the state, you know, our people.
Well, even the Hospital Association has proposed a plan whereby they would contribute some to the state's share under Medicaid expansion. Well, what about this as an idea? Perhaps they could contribute to a fund that would at least cover some, if not all, of the deductibles and copays. And by the way, there's still cost-sharing reductions. They call them CSRs. Mm-hmm. Those are available at 250% of the federal poverty level and below that offset the majority of the cost of deductibles and copays.
I wasn't at the hearing, but I did see a soundbite or hear one from Tim Moore, and they talked about that. But my understanding, you know, they're under significant financial problems right now, and that money that I think they previously put out there, is it still there? Right?
I'm not sure.
I don't know.
Yeah, it's a good point.
Great idea, and I think all ideas are on the table of how we get through this, but I'm very concerned about this 54% of hospitals that are at risk and what that means for physician practices. We've worked so hard to get people into these rural areas. You know, if they can't deliver babies, where does the OBGYN go? They leave.
Dr. Edney said estimate of 38 of the rural hospitals statewide are in danger of immediate cuts in service or closures in the near term.
Right.
This is what, and I want you to confirm this with me, Dr. Bryan, because you work in the industry. If that would happen, I know there's at least a perception, as we are rather comfortable here in central Mississippi. We've got great high-quality health care, and it's our demand and supply is not nearly out of balance as it is, let's say, in these rural hospitals. Mm-hmm. We don't have quite the economic challenges because we have more people that have private insurance, et cetera. I mean, that's just all part of the model. But if these facilities close, if 38 of these hospitals in the rural areas close, that's going to get essentially dumped, and I excuse my crass language, on this community.
Oh, yeah.
That's what's going to happen.
And also people will die trying to get to this community because you and I are used to jumping in our car and running down Lakeland Drive. That can never happen. I mean, as the people, I just cannot envision a time in which hospitals would just shut down and people would just not have a fit. I mean, it just can't happen that we lose that level of access. I do think we're going to go through some tough times as our leaders work all of this out. I think, too, back on that MHA money, I'm not even sure if when they did offer it, did they accept it or did they have a conversation?
Well, no, we could get Medicaid expanded.
Right. So, yeah, I mean, it's moot. There is an answer somewhere in here that, you know, I think South Dakota just voted.
They did. They just voted.
Right. So there's 11 of us. And look, I mean, I want what's fiscally responsible and what's best. And I do think that there is, well, I know that the numbers say the economic boom is there, the healthcare jobs that are created, and we are on the bottom. Yeah, we're on the bottom. I know. And the postpartum expansion, to me, is the low-hanging fruit. And that didn't get through either, as you know. But at a minimum, though, this is law. This Obamacare enhancement that I'm talking about, that has been passed into law. Right. And that's at least good for 3 years. But I have no problem saying to the audience here, once you put things like that in place, even though they expire in 3 years, they're never going away. No. They're just never. I heard the same thing when Obamacare was passed. Oh, yeah, but the Republicans are going to come in and repeal it. No, they're not. Ever. But on the same thing, like in the 60s when Medicaid first started here, and then again now, it's like, well, what if the money is taken away? You know, that's never going to happen either. Right. So there are a lot of reasons to oppose Medicaid, and that was one of them. That's not a reason.
That's not a reason. Saying that the federal government's going to wilt on you, they're not going to wilt on 40 states.
No,
That's just not going to happen.
And I have to say, too, that even those who have been the staunchest, like we have lived through a really trying time, and healthcare workers are at their brink. And what do we do, right? I mean, even doctors, when you look at the national data, I think it's over the next 3 years that 1 in 5 are going to retire, quit, or leave.
That.
What are we going to do then? I mean, thankfully, we're increasing our medical school class size, but that takes time. So it all works together on an access to care. And again, I heard Dr. Edney on here the other day talking about we're not just 50th or 50th by a mile, right?
Right. We got a long way
if
just
there
to
was
get
a 60,
49.
Yeah.
That's absolutely true. And that's disturbing as a Mississippian. And I know I can see it in your face and hear it in your voice. It bothers you, too. We're not being critical. We want to fix it. We want to make it better.
We can come together on this. I know that we can, because reasonable minds can come to reasonable solutions.
Yeah, I totally agree. But I hope if there's one thing that's taken away, I sure wish you and folks out there listening that know a lot about this and work in the industry would really take a hard look at these enhancements in the exchange subsidy model that just got enacted. We should be leveraging that, promoting that, seeing if we can't get people to sign up. Maybe it's not 100% totally free like Medicaid, but it's better than nothing, and the hospitals get reimbursed. That's the important thing as well.
I appreciate your passion and continue to spotlight what's going on in healthcare across our state. You know, it may get a little harder from here, and we just got to plow through.
Appreciate
so thank
it.
you. Mm-hmm.
Thank you, Dr. Bryan. Coming right back.